Now we come to endometriosis. So what is endometriosis? Endometriosis is ectopic presentation of endometrial tissue in the myometrium. Sorry, outside the uterus, not in the myometrium. That is adenomyosis. Ectopic location of endometrial tissue outside the uterus, in the pelvis, in the abdominal cavity, anywhere is endometriosis. Okay, so endometrial tissue, gland and stroma both. So whenever endometrial tissue is lying, it has gland and stroma both. Outside the uterus is endometriosis. It can be there in pelvic viscera and peritoneum. The most common site of endometriosis is ovary. Most common extra pelvic site. So that is the most common pelvic site. Structure in the pelvis, most commonly it is located in ovary. Most common extra pelvic site is colon. Rarely it can be present in heart, lungs and everywhere else. It can be present anywhere. So what is the epidemiology? What is the incidence? How common it is? Basically, not every time it is symptomatic. It has been seen in almost 10% of patients as an incidental finding, which have no symptoms. 10% of women have ectopic endometrium without any symptom. But if a patient comes to you with infertility and pain, her main symptoms are pain, dysmenorrhea and infertility. In such a triad, it has been seen to be present in almost 20 to 90% patient. Why such a big variation? 20 to 90. Because see, endometrial diagnosis is very tough. Endometriosis diagnosis. It is basically dependent on the surgeon's experience. There are very small endometrial tissue that is present in abdomen. It is not something very clear. And none of the tests are none of the diagnostic tests are perfect in diagnosing not very sensitive in diagnosing endometriosis. Endometriosis is diagnosed basically by doing laparoscopy and visualization of the cavity. So it depends on surgeon's experience. Those who are very experienced will look and understand that there is endometriosis. Those who are not might miss it. That is why incidence is ranging from 20 to 90. Some will diagnose it in 90% patients, some will diagnose it in 20% patient. But a patient with infertility and pain, in them endometriosis is far more common. Okay, what are the risk factors? Anything so why the endometriosis is happening? Whenever there is a lot of blood, whenever the patient is bleeding, there is some regurgitation. As such, the menstrual blood has to come out through vagina. But instead of coming out through vagina, if some of it regurgitate through the tubes into the cavity, into the pelvis, that will give rise to endometrium. So whenever there is more bleeding, the risk of endometriosis are more. Like in an infertile patient. An infertile patient who has never been pregnant, she has been menstruating all her life, the risk is more. When patient is pregnant, she is not bleeding for 9 months. Further, she is not bleeding for 6 months when she is lactating. So obviously, she is bleeding less in her lifetime. So risk is more in a nulliparous and an infertile patient. Then early menarche, late menopause. So as earlier you get menarche, more you bleed. So that is why again you are at more high risk. Hypermenorrhea. That is clear. Mullerian anomaly. If there is any Mullerian anomaly, the chances of blood regurgitating into the pelvis is far more. Diethylstilbestrol, because it is a cause of Mullerian anomaly, abnormally shaped uterus. So diethylstilbestrol use, and it has been seen to run in family also. So these are the risk factors. So if these are the risk factors, what are the protective factors? So what are the risk factors? So why the endometriosis is happening? Basically, the menstrual blood which is getting collected in the uterus has to come out through vagina. But for many reasons, along with coming out in vagina, it regurgitates through the tube. So tube is another opening of uterus. Through tube, it regurgitates in the pelvic cavity, and that gives rise to this ectopic endometrial tissue. So that is the reason for endometriosis. So anything which increases the frequency of menses will increase the risk factor for endometriosis. Like an infertile patient. A patient who is infertile has been bleeding throughout her lifespan. A patient who is nulliparous. Because when you get pregnant, you don't bleed for 9 months. You don't bleed for another 6 months when you are lactating. So your frequency of bleeding is less. Whereas a nulliparous woman has been bleeding all through her lifespan. So risk of endometriosis is more in infertility and nulliparous women. Similarly, early menarche and late menopause. When you have early menarche, when you have late menopause, the cycles you are having is more. Similarly, hypermenorrhea, any Mullerian anomaly, any anomaly of the uterus will increase the regurgitation of blood, like use of diethylstilbestrol. It also deforms the uterine cavity, and family history. So, it does run in the family. So, these are the risk factors. So, if I can write the protective factors based on that, what will be the protective factors? Multiparity is a protective factor. Lactation is a protective factor. Smoking, smoking decreases the estrogen levels, so smoking is a factor. Then use of fresh fruits and vegetables, keeping a healthy diet is also a protective factor, right? Okay. Now, endometriosis and risk of cancer. So, many times some people say that endometrial tissue can change into cancer, but now it has been seen the risk of cancer in the ectopic endometrial tissue is same as in the endometrial lining of uterus. So, there is no increased risk. So, it was very controversial, and it was said that the risk is same as of uterine cancer. It is the same tissue. So, if somebody has high risk of uterine cancer, the cancer developing into ectopic endometrial tissue is the same. There is no increased incidence, right? Now, how does endometriosis happen? One theory I told you, the regurgitation. Basically, there are three theories given for endometriosis. One is the ectopic transplantation. This is called as Simpson's theory. They said that when there is bleeding, there occurs regurgitation and the blood gets lodged in the pelvic cavity. So, correct, it seems correct, but it does not explain the change of ectopic endometrial tissue in areas like bowel, in abdominal cavity. Why does it happen? So, they say there can be coelomic metaplasia. There is another theory. The coelomic epithelium, which is there in the abdominal cavity, in the perineum, in the peritoneum, it undergoes metaplasia by itself. So, it can go metaplasia and that can convert into the endometrial tissue. This explains the abdominal endometriosis. But endometriosis can happen in lungs, it can happen in heart, it can happen in cesarean scar. There came the induction theory. They said because of lot of inflammation and inflammatory mediators, any site can very well undergo change into the endometrial histology. So, because of recurrent inflammatory conditions, endometrial histology can be changed. So, these are the three theories which are trying to explain why the endometriosis is happening. Simpson's theory, which seems most easily explainable, and it explains the pelvic ovarian pouch of Douglas endometriosis. Then the coelomic metaplasia, which explains the abdominal endometriosis, and then induction theory, which explains endometriosis in the distant areas. How will the patient present? So, patient will have very good triad of infertility, dysmenorrhea and dyspareunia and chronic pelvic pain. Why the pain is happening? So, there is tissue outside the uterus which is bleeding with every cycle. Now, that bleeding is not going anywhere, the tissue is bleeding and bleeding is getting collected. So, there is lot of inflammation happening. That is leading with every cycle, lot of inflammation is happening. That is why dysmenorrhea is happening. Then there occur deep invasion. When there occur deep invasion, that also leads to pain. So, deep invasion leads to chronic pelvic pain, and when there is repeated bleeding in that endometrial tissue, there happen to occur adhesions. And these adhesions become very painful when the tissue is stretched. So, on stretching, this becomes very painful, and that is the reason for dyspareunia. So, during dyspareunia, when the movement of the tissue inside is happening, because of adhesions, it becomes very painful. So, every kind of pain can happen with endometriosis. Dysgesia, dysmenorrhea, dyspareunia, everything, chronic pelvic pain. So, because of so much inflammation and adhesions, there occurs pain. That is how patient present, and infertility is also very common. Then, other than that, if it is located in the colon and the GI symptoms, GI area, it can cause pain, nausea, vomiting and bloating also. Dysmenorrhea is very characteristic of endometriosis. What kind of dysmenorrhea? How you can differentiate it from a primary dysmenorrhea. Primary dysmenorrhea is something which occurs in every ovulating woman because of lot of prostaglandins released. It is physiological. How it can be differentiated? Because it starts before the menses and it continues throughout the menses. When we will read dysmenorrhea, we will learn how to differentiate between a physiological dysmenorrhea and a pathological one. So it starts before the menses and it continues throughout the menses. Then this kind of dysmenorrhea is generally bilateral, but remember one thing, having severe dysmenorrhea does not mean patient is having severe endometriosis. Pain has nothing to do with severity of endometriosis. Basically, it has to do with the invasion. If it is deep, then there are chances it will be painful. It does not need to be severe. The lesions need not to be too many. If they are metabolically active lesions and they are deep lesions, the chances are more. If the lesions are metabolically inactive, they are not deep, the chances of pain are less. So it does not depend on how severe it is. There might be a lot of adhesions inside and it might be still not painful. So pain has no relation with the endometriosis severity. How it will be presented clinically? Infertility will be happening. Cause of infertility are a lot. They are basically theoretical causes. As such, not asked in PG, but yes, in university exam they can be asked that why endometriosis is doing infertility. Why? First, because the ovaries are involved and it causes adhesions and the ovaries got stuck with each other. So it will inhibit the ovulation. Then all the adhesions will make the tubal motility weak. Tubal motility will also decrease and as a result ovum pickup by the fimbria will not happen. Because of adhesions involved, the fimbria might not work properly. So tubal motility is affected, ovum pickup is affected. It is seen something called as luteinized unruptured follicle. It is seen when the patient has so much endometriosis, somehow the follicle does not rupture. It has reached till the Graafian follicle stage, but it will not rupture. It is called as luteal insufficiency, luteinized unruptured follicle. And there is also altered immunity. That is why it runs in family. So all these lead to infertility in endometriosis. Other than that, there can be other endocrinological abnormalities seen associated with endometriosis. They are not caused by endometriosis, they are seen associated in a patient of endometriosis like anovulation, impaired follicle growth, disturbed LS surge. So disturbed LS surge is not because of endometriosis, but it has been seen associated with it. Then galactoria and hyperprolactinemia has also been seen. So there is some confounding factor which we are not able to deduce right now, but they are associated with endometriosis. What about extrapelvic endometriosis? Most common is GI, colon. So how will it present? Extrapelvic one, the GI symptoms like bloating will be there. There can be bleeding during the menses, there can be rectal bleeding, cyclical pain will be there. Then there can be very rare presentation of pneumothorax, hemothorax and hemoptysis during menses. But remember, these symptoms will happen during menses because that is the time when endometrial tissue is actually active, right? If you will examine, what will you find? Many times nothing will be found. The tissue is lying outside uterus. When you are palpating uterus, you will not find anything. It is not enlarged. Why will it be enlarged? There is nothing inside uterus. So no abnormality will be detected. But many times there can be other things like there are adhesions, so there can be immobility. So uterus can be normal size but immobile. That can be seen. Sometimes there can be endometriotic nodules in the rectovaginal area which you can palpate. And this, as I told you, pain is not related to severity. Pain is related to the site of ectopic endometrium. Rectovaginal endometriosis is the most common cause of dyspareunia. So when the endometric tissue is lying in the rectovaginal area, then the movement will cause severe pain. So it is the site which decide whether it will be painful or not the severity. So there you can find nodules in the pouch of Douglas near the rectovaginal septum also. There can be sometimes endometriosis of the ovary leading to cyst formation. Every time this tissue bleed, every time blood will get collected, as a result the ovary will be enlarged. And there will be lot of blood in this ovary. And since when the blood is getting collected, it is not red colored, it will be brown colored. So we call it chocolate cyst. So on examination, you can find ovarian enlargement. And in advanced disease, when everything is adhered with each other, there is frozen pelvis. Means you can palpate uterus, but everything seems to be stuck to each other. That is frozen pelvis. So this is the examination finding. Okay. So now comes imaging. The first step, what we will do, a patient comes to you with infertility and pain. What will be your first step? Get an ultrasound. Ultrasound is not very sensitive for endometriosis. They are very small ectopic tissues, small endometrial tissue. But you can still see certain things, like you can see chocolate cyst, like this. This is chocolate cyst. This one is ground glass appearance. Ground glass क्या होता है? What is ground glass? You might have seen certain glassware, certain crockery which is brownish, which is not very clear. It is not opaque. It is glassy, but it is not a clear transparent glass. Very old crockery used to come. That is ground glass, translucent glass. So ground glass is ectopic. Can you see this clear cyst? That's an ovarian cyst, simple ovarian cyst. But this ground glass is because of chocolate color blood filled, that is endometriotic cyst. So simple cyst with no solid parts. What else you can see? You can see this endometrioma. Deep tissue, deep endometriosis, big endometriotic tissues can be seen, but it is not very diagnostic. It is not good in diagnosing the endometriotic patient, but obviously it is the first step, right? Then what else you can use? You can use CT scan and MRI, but CT scan and MRI can only detect the deep lesions, which are more than 5 mm, that only CT scan and MRI can detect. Small peritoneal lesions will not be detected by it. HSG is hysterosalpingography. What will it do? It is a dye injected inside uterine cavity. Everything is normal inside uterine cavity. What is happening outside uterus. So it will not help us. Other ultrasound like transrectal CT, yes, if the symptoms are there, then you can do it. Otherwise, they are all not helpful. What about any blood test? Yes, endometriosis is there is increase in CA125 because it is basically secreted from the coelomic epithelium. So CA125 can be seen raised, but it is also a marker of ovarian cancer. And CA125 is increased in other conditions like inflammation, liver pathology. So it has no diagnostic value as such. It's just that you can see it raised in many other conditions. Like in tuberculosis also CA125 is raised. So it will be raised. The range is almost 19 to 45 international units, but it is not diagnostic. Laparoscopy is the one where you can visually recognize. But obviously, it is very much surgeon specific. It is not that all the surgeons, all the lesions can be visible. How will it be seen? Can you see how small it is? It can be like this powder burn appearance. You can use these small powder burn appearance. They can be red inflamed, they can be whitish lesions. They are the old endometriotic tissue. Red inflamed lesions. You can see adhesions. Then you can see chocolate cyst. And you can see ovaries, which pouch of Douglas completely adhered with each other, frozen pelvis. So it is very much surgeon specific. But laparoscopy can help you visualize. One thing in which laparoscopy can help is you can take this tissue and send it for histopath. That is something in which laparoscopy is helping us. Right? So what is helping in final diagnosis? We said ultrasound can see only the chocolate cyst, not very good. CA125 is raised in other conditions, not very good. MRI and CT can see only the deep lesion, again not very good. Then what will we do? Basically, it is culmination of everything. It is culmination of the patient's symptoms, which are characteristically what? Infertility with lot of pain, especially dyspareunia. Plus you saw it visually via laparoscopy and you did the final diagnosis with histopath. So all this will make the diagnosis. Now what to mark in question? Many times the question comes, what is the gold standard for endometriosis? The gold standard is laparoscopic plus histopathology. That is the gold standard. See the lesion, take the tissue, do the histopathology. That is the gold standard for endometriosis. Revise again, what was the gold standard for fibroid? Ultrasound. What was for polyp? Hysteroscopy. And what is for endometriosis? laparoscopy plus histology, because there is no other way of collecting the tissue. That is the gold standard. Okay? Yes. So what we have read in endometriosis, it is basically an endometrial tissue which along with its gland and stroma lying outside the uterus. Most common site in the pelvis is ovary. Most common extra pelvic site is colon. How the patient will present? A triad of infertility, dysmenorrhea and dyspareunia. It has nothing to do with the site severity. It is more related to site. What is the most painful site? Rectovaginal septum. Diagnosis, first test is TVS but very less sensitive. The highest is laparoscopy and histopathology is the gold standard. How are you going to manage this patient? They can be managed medically or surgically. Now the management of this condition is tough. So you can either give hormonal contraception for long term, constantly for 3 months. What will happen? The endometrial tissue will stop bleeding and constant estrogen progesterone will lead to absolutely no bleeding, and as a result there will become atrophy of this ectopic tissue. So extended use of OCPs or plain progesterones can be done. GnRH agonist, since it completely shut down the HPU axis and decrease the estrogen level, can very well result in shrinkage of the endometrial tissue. So it will provide temporary relief, but it cannot be used for long period of time. So once GnRH agonist is stopped, it can recur. It can recur. Endometrial tissue can flare up again. But by the time you are giving it, it will be controlled. So you can try extended OCPs which can be given for long term. Okay. Anti-progesterones can also be given, right? So if you read about hormonal contraception, low dose OCPs can reduce the pain and the bleeding. That can happen, but you have to use a continuous pill. If you use it for 28 days, patient have bleed again for 28 days, what is the use? Endometriotic tissue will bleed. There is no use. So give it for extended time so that patient does not bleed at all. Then other than that, medroxyprogesterone acetate, Dynogest, cyproterone acetate, they are all the progesterones. Norethistrone and danazole, antiprogesterones, gestrinone, they all can also be used. Long-term progesterone. So what is progesterone role? Progesterone karta kya hai? Its role in endometrium is, it is very much anti-estrogenic. It decreases the estrogenic effect on the endometrial tissue. It is very much anti-mitogenic. It decreases the thickness and the growth of endometrial tissue. So long-term progesterone will also help. Or GnRH agonist, obviously with add-back therapy that we have read. Or you can give plain simple analgesics, but they are not very effective because the pain is severe. Can you operate? Yes. If you are doing a laparoscopy, then if there is pain, you can definitely do the excision and ablation. Whatever lesions you are seeing, you can excise and ablate it, but the relief will be 100%, that cannot be assured. So operative laparoscopy is more effective for pelvic pain. So if the main problem is pelvic pain, if you ablate the lesions, it can be effective. If you do the adhesiolysis, if you release the adhesions, that is the main cause of pain during the movement, pain will be decreased. Okay. Or interrupt, some high-end surgeries, just know the name, interruption of pelvic nerve pathway, like laparoscopic uterosacral nerve ablation. Cystectomy, if you see an ovarian endometrioma, do you need to do cystectomy? No. Unless pain is the main symptom, don't do it. But if the cyst is more than 3 cm, you have to do cystectomy to rule out ovarian cancer. It can be an ovarian cancer which you are not able to diagnose. So any cyst, any endometriotic cyst more than 3 cm has to be removed. Cystectomy is the procedure, not the drainage. Drainage होता है कि आपने cyst छोड़ दिया है. Cyst is there, you just drain the blood out. Cystectomy means removing the cyst. So cystectomy followed by histopathology has to be done everyone who is more than 3 cm cyst. Drainage is not done. Hysterectomy is the definitive surgery. Okay? Remove the ovaries and all the lesions, that is the definitive surgery. But again, it might not completely cure. There might be lesions in the peritoneum which you have left. They might again start flaring up. But if you have removed ovaries, the chances are they will not flare up. In case of infertility also, in case it is mild and moderate, ablation and adhesiolysis might help. So, but very controversial result. So, basically what we have read is the management is not very helpful. Medical management mein you can do extended OCPs and progesterones. You can also give GnRH agonist. And surgical excision mein, if the cyst is big, you do cystectomy, and hysterectomy is the definitive treatment as nothing is helping. So, it's a vague kind of presentation and vague kind of treatment. Next, we will read the adenomyosis.